Hello everyone, welcome back. Today I'll be covering regarding a surgical management of spinal tuberculosis, the past, present and future. Adapted by study by Ruparel et al. 2022. Now let's get started. As an introduction, the principles of management for spinal tuberculosis are different as it affects neurology, biology, and mechanics. Management strategies have changed due to the development of bacillus-calmette-guerin BCG vaccine and effective anti-tuberculous drugs. From watchful observation to aggressive debridement, to selective surgical indication based on the well-formed principles. The past. Spinal tuberculosis described by Percival Pott in 1779 as that kind of palsy of lower limbs which is frequently found to accompany a curvature of the spine. Mainstay of treatment was immobilization using body cast or plaster bed. Aim is to achieve the stage of ankylosis in the least disabling position. The results is disappointing. Only 30 to 44% resume full working capacity. The rest either died, around 30 to 50%, or were paralyzed and severely crippled. Development of anti-tuberculous drugs in the mid-19th century allowed surgeons to directly assess and debride the site of pathology. Many reports shows effective penetration of drugs in bony lesions, including cavities and abscesses. Thus, the principles of radical anterior debridement as proposed by the Hong Kong group. Medical Research Council MRC trial result led to the development of the middle pathway by Tully. It divided into three groups: the drug treatment group, the debridement group, and debridement with anterior spinal fusion group. All had similar outcomes at 15 years in terms of healing. Deformity progressed in the first two groups. Study by Olga et al. Conducted that the tubercle bacilli did not adhere to metals and form biofilms, making it possible to use instrumentation at the site of pathology for immediate stability and to further improve the quality of life of patient. The present. Tuberculosis of the spine is now regarded as a medical disease with indications of surgery. Pathology causing a neurological affection or deformities. Compression of surrounding vital structures due to an abscesses. Clinical deterioration despite anti-tuberculous treatment. Please take note. The principles of surgical management include addressing the lesion with optimum debridement and decompression, restoring the stability of the spine with adequate bone-on-bone contact for fusion, using a strut graft, either autograft or allograft, or titanium mesh cage spanning the site of decompression. Immediate stability is provided with instrumentation that leads for early mobilization. Using a surgical approach that is most effective and least morbid to the patient coupled with effective anti-tuberculosis treatment. Optimal decompression includes removing the offending structures causing a neurocompression with loose sequestrated pieces of the bone and disc and drainage of pus pockets. Radical debridement until there are bleeding bone edges is not recommended as it causes large anterior defects requiring reconstruction. Immediate stability with instrumentation, either anterior or posterior approaches, promotes healing and enhances the fusion rates. Study by Rajasekaran, the Pediatric Spine Instability Score. Please take note. For spine at risk sign, number 1, facet subluxation or separation of facet joint. 2, retropulsion. 3, lateral translation. 4, toppling sign. This assesses the severity of the progression of the deformity. Each radiological sign is allocated 1 point with a maximum possible score of 4. A score of 2 or more is considered unstable and requires stabilization. This figure illustrates the spine at risk radiological sign. A, separation of the facet joint or facet subluxation. You can see from the red illustration and the distance, there is an increase in distance between each facet joint. B, retropulsion. The bone retropulsed posteriorly. C, lateral translation, moving side by side. D, toppling. Yay! We have reached to the end of this video. Okay, sorry. See you in the next one. I will do a part 2 that covers regarding the surgical management of tuberculosis. Take care and bye.